you are making an introduction?
Yes, ma'am.
Yeah, please.
Okay. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect. Welcome you all for today's webinar, Non-Obstetric Causes of Pain Abdomen in Pregnancy, organized by Foxy Society of Chennai and A4 Hospitals and Fertility Center, Chennai. So it's my privilege to introduce the moderator of today's webinar, Dr. K. Balakumari, ma'am. Ma'am is the head of obstetric units of A4 Fertility Hospitals, gold medalist from Stanley Medical College, and passionate teacher, mentor, and an advocate for women's health. Ma'am is currently the chairperson of Foxy, executive committee member of Oxy. I welcome
Thank you,
you, ma'am.
Sahiti.
Yes. And it's my
Yeah.
honor to introduce Dr. Sudha Krishnan, ma'am. Ma'am is the consultant obstetrician and gynecologist at A4 Fertility and Maternity Hospitals, Chennai from 2025 to present, and consultant and specialist at Kaula Hospital, Oman. Experience in managing high-risk pregnancy and complex gynecology cases, hysterectomy, laparoscopy, and fertility care. I welcome you, ma'am, and I hand over the session to moderators.
Thank you.
Please put Dr. Jayapriya's slide.
Sure, ma'am.
Introducing her. A very good afternoon to all of you. I'm very happy to introduce Dr. Jayapriya, definitely a youngster when compared to us. And she is from Ramchandra Medical College. She did her undergraduation there. She is an MRCS and she has got 20 years of clinical experience in general and laparoscopic surgery. And she's a senior consultant at Hindu Mission Hospital, Tamram. She has presented more than 15 papers in 15 papers and 4 peer-reviewed publications. And you can see her publications in laparoscopic cholecystectomy, minimum access surgery journals and Eurasian journal. And she has been awarded Shushruta gold medal and few other gold medals as well. She is currently working in your Dr. Jayapriya, I'm not able to see the full slide in my. Where are you?
I'm working in Hindu Mission Hospital, Tambaram, and I do private practice as well.
Okay, very, very nice to have got you for this seminar. Welcome, and now the stage is yours. You please go ahead.
Thanks, Balakumari madam. Nice to know you. And it literally feels like an FRCS Viva here. I'm the only one with the video on and prepared and here nervous to talk in front of all of you. It'll be kind enough if some of you can turn your videos on, if feasible, possible, and if you don't feel breach of privacy.
Yeah, something has gone wrong with my video. That is why I'm not able to open it. And maybe probably I will leave and then join again if possible. And others, please switch on.
So if you can, otherwise rest assured, I understand your feelings because so many webinars I've attended in my night clothes, pajamas, without washing my face and doing my hair. So thanks for being there this afternoon. Thanks for this opportunity. So I shall begin. I'm starting to share my slide now.
I will probably leave and rejoin so that I'm visible. But you please go ahead.
So I start off. So the topic for today is non-obstetric causes of abdominal pain in pregnancy. I hope everyone can hear me. Yes. Give me a thumbs up. Some emojis will work if you can't show your faces. So give me a thumbs up if you do. And
you're audible.
Okay. So I will run through these in my talk today. The causes of abdominal pain in pregnancy, the overview of abdominal emergencies, the organ pain correlation. I'll stress about appendicitis and gallstone disease, laparoscopy in pregnancy, and I will summarize. Coming to the causes, my first few slides will talk about all the textbook causes. So bear with me. So the commonest causes, appendicitis, they present with right lower quadrant pain, nausea, fever, gastroenteritis, peptic ulcer disease, cholecystitis, biliary colic, pancreatitis, intestinal obstruction, genitourinary causes, urinary tract infection, pyelonephritis, ureteric colic, bladder pain syndrome. Rare causes are vascular causes such as aortic aneurysm dissection, mesenteric ischemia. Common causes again are abdominal wall strain, rectus sheath hematoma, hernia such as an umbilical or an inguinal hernia. Gynecological causes, this you're all experts. I understand the audience is obstetricians and gynecologists, so you will all be much more well-versed in these causes than me. Referred causes such as lower lobe pneumonia causing pain on inspiration, myocardial infarction, diabetic ketoacidosis, porphyria, sickle cell crisis. So what is the incidence of non-obstetric emergencies in pregnancy? So the surgical emergencies in pregnancies are low. One should be aware of the possibility of appendicitis, but its incidence is lower than in the non-pregnant woman. Hormonal changes can increase the ultrasound scan findings of gallstones and sludge in pregnancy. The absolute numbers of torted and hemorrhagic ovarian cysts are low in pregnancy. Fertility treatment with GnRH analogs involving controlled ovarian stimulation appears to increase these risks. So before I move on, I request the audience that you can stop me in between, ask any doubts I would like to clarify, and I will stop, clarify, and proceed. So this slide shows us the incidence of the possible abdominal emergencies in pregnancy. If you look at appendicitis, the incidence is 1 in 1,000 to 1,500. If you look at the fetal risk, it is 3 to 5% in unruptured appendicitis and 20 to 25% in ruptured appendicitis. Cholecystitis, that is acute cholecystitis, is 1 in 1,600 to 10,000, whereas cholelithiasis, the prevalence of gallstones leading to mild belching, burping, biliary colic is 1 in 3 in 100. So cholelithiasis is quite prevalent in pregnancy. Pancreatitis, 1 in 1,000 to 10,000. Small bowel obstruction, 1 in 3,000. Trauma, 6 to 7 in 100. This is the global prevalence as per this paper published in 2008. I don't know the current prevalence. The gynecological conditions such as adnexal torsion, degenerating myoma, uterine rupture, again contribute. So why are we concerned about abdominal pain and emergencies in pregnancy? So without appropriate surgical treatment, conditions such as appendicitis, cholecystitis carry specific risks in pregnancy, which include peritonitis, maternal sepsis. This in turn results in miscarriage in the early trimesters, preterm delivery, and stillbirth much later. So coming to the organ pain correlation, this is a very, very basic concept that is taught to us during MBBS. When you go for general surgery training postings, so right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant, epigastrium, suprapubic region, umbilical region. So these are all the quadrants that we divide into, and based on the organs that are nearby, we kind of decipher where the pain comes from. This is the usual 9 quadrants that we describe in general surgery training as well as in final MBBS general surgery postings. So the right hypochondriac region, there is a liver, gallbladder, right kidney, small intestine. Right lumbar region, there is again the gallbladder if it's pushed down, right colon, liver, right iliac fossa, the appendix and cecum. Epigastric region, stomach, liver, pancreas, duodenum, spleen, adrenal glands. Left hypochondriac region, spleen, colon, left kidney, pancreas. Left lumbar region, descending colon, left kidney. So, and so on and so forth. So, someone comes with pain in the left iliac fossa in pregnancy, you've ruled out your ligament pains and everything. Usually it's because of constipation, some straining. If it's right iliac fossa, we think of appendicitis. Later in pregnancy, when the appendix is moved up, you consider even a right hypochondriac pain to be appendicitis, etc. Again, a diagrammatic representation of the quadrants and the organs causing symptoms in those quadrants. Oh, this slide, everyone will be familiar with this picture, how the McBurney's point, which is a clinical sign elicited in acute appendicitis, it keeps moving up during pregnancy. So appendix is a very mobile structure. Even in an acute appendicitis in a non-pregnant patient, many a times we don't find the classical tenderness in the right iliac fossa. I recently had an 18-year-old girl with acute appendicitis. She presented to me with suprapubic pain, hypogastric pain. And clinically, right iliac fossa plumb normal. And I sent her for an ultrasound. We did not pick up the appendicitis. She was a little warm, no obvious fever, slight reduce in appetite, but the pain was there and tenderness was there. We did a CT. CT showed an inflamed appendix. It is sitting in the behind the bladder, urinary bladder. So due to the varying position of appendix and in pregnancy, because of the gravid uterus which keep pushing the appendix up, the appendicitis can even present with tenderness in the right upper quadrant, just like a acute cholecystitis.
What's the percentage of people whom the ultrasound helps in the diagnosis? Like roughly, say 50-50, like you don't rely 100% on the ultrasound, definitely.
Yeah. So, ma'am, I don't know an exact number to tell you. So, in my practice, for example, right after my residency, I joined an ultrasound unit, a radiology unit, just to pick up sonography skills, just like, gynecs do. So, there is one senior consultant. He would not do a CT KUB to diagnose renal stones. He would just pick it up by putting the scope on the urinary bladder. He will turn the Doppler on and he will put it at the trigone. He'll look at the squirt of urine in the ureteric orifice on the right side. He'll look for the squirt on the left side. He'll turn the patient and travel all along the kidney retroperitoneum just with this probe. So what I'm trying to say is depends on the expertise of the sonographer, depends on the gas. So I'm trying to say I don't know the answer. So
Yeah.
I really don't
just
know.
to convince a patient that ultrasound cannot detect appendicitis, and we have to more rely on our clinical skills.
So
that's exactly I want to convey to the younger generation.
Yeah, because now I'm 5 years in private practice, so I was in institutional practice. Institutions, we know the radiology department, we know who's senior, we know who will pick it up, and we know where to push and pull to get our diagnosis. In private practice, we come across a variety of patients who live in different parts and with different affordability issues. So when I know this patient has gone to this particular place, this particular radiologist, I might not trust the report. If I know a particular radiologist is good, I will call up and discuss with him or her. So yeah, can't quite. So ultrasound may not be diagnostic of appendicitis, not only in pregnancy, even in non-pregnant status. So now it has become the standard to do a CT if we have any doubts on the scan, but clinically we know it's appendicitis.
CT we cannot during pregnancy.
Yeah.
Doesn't MRI help? In what way is CT different from MRI in this particular incident?
So MRI will be the investigation of choice in pregnancy. It beautifully picks up appendicitis. CT obviously we don't do because of the radiation exposure. So in terms of how different are CT and MRI? So to the practicing clinician like me, general surgeons, we are used to reading CT.
Okay.
So it's easy for us to read it. MRI is like Greek and Latin. So we don't see MRIs every day. So we are totally dependent on the radiologist.
Okay.
Report it for us. So that is point one. If you look at the sensitivity of MRI, definitely it's superior than CT. We don't routinely do MRIs in clinical practice to pick up appendicitis because CT is easier, quicker. We can read it ourselves. The patient is in and out in like 2 minutes for a plain CT, maybe 5 to 10 minutes for a contrast CT. And all patients won't be very amenable for MRI. There's claustrophobia and other things. So yeah, and many times we need to do other things in the abdomen in an MRI, like, colitis or this or that. And we are familiar with CT, so we go for CT, but MRI definitely better than CT to pick up appendicitis.
Okay.
Thanks, ma'am. That makes this interesting for me. So as we all know, this diagnostic flow chart, one has to be absolutely honest, like a final MBBS, to be able to go through the entire history, the clinical exam, and then proceed to labs and imaging, consider differential diagnosis when you're dealing a patient with abdominal pain, especially so in pregnancy. I understand how obstetricians rake their brains to be able to figure out where the pain is coming from. Imaging, ultrasound is first line, safe in pregnancy, economical, available. MRI is a safe alternative if ultrasound is inconclusive. In fact, the procedure of choice, investigation of choice. CT, I'm sorry, but I can't even say this in this forum. Absolutely contraindicated is what I will say. There is some scientific evidence that says, okay, in the final trimester, when you've decided to deliver the baby, regardless, you could still go ahead if there's a diagnostic, but I don't think any of us will dare do that. Will we? I don't know. The senior obstetricians say.
I think late trimester, it increases ionizing radiation, increases the carcinogenesis of the fetus. So everybody will be more cautious of using CT in pregnancy as such.
I shouldn't be able to say this here. But is it true? I mean, can I ask, is it true that you could, not for the abdomen, for suppose a chest CT or something, could you cover the abdomen with a radioprotective material?
Yeah, you can shield and then do. Only thing is we have to discuss with the radiologist. The maximum dose of radiation exposure to the fetus should be less than 5 rads. Then it is okay. They say the safe limit is less than 5 rads, and depending upon the gestational age as well. So whenever you are doing upper chest, if you are suspecting PE, mother comes first. So you can shield the abdomen, counsel the patients and relatives full whatever is there, and then you can proceed with the CT chest if need.
So going on to appendicitis, this is the most common non-obstetric operative emergency during pregnancy. It amounts to 25% of operative indications for acute abdomen during pregnancy and puerperium. Pain in the right lower quadrant is the most reliable symptom, and abdominal tenderness is almost always present. And fever and tachycardia are positive signs. Leukocytosis, this is not diagnostic because elevated levels are found during pregnancy and especially in early labor and pregnancy. Whereas neutrophilic leukocytosis, it is diagnostic as it is a sign of bacterial infection. So it's good to go for the differential count when in doubt. Abdominal ultrasound is usually the first investigation with less accuracy in the third trimester.
Do you always do CRP along with this? C-reactive protein.
I sparingly use CRP in my practice, madam. CRP comes when there is a diagnostic dilemma. So when I'm clinically sure this is appendicitis,
then you don't have to.
The counts are raised, or even if the counts are not raised, if there is a neutrophilic leukocytosis, imaging is contributory, we end there. CRP I used sparingly in certain cases where, there is a non-healing wound, I'm not sure, something recurred, there is a post-operative complications, I don't know whether to give antibiotic or not, I don't know this is a chronic sinus because of TB or an acute. So in those kind of dilemmas, I kind of use CRP to reassure myself, to make sure, I'm not going the wrong way, to track. Yes, so I always don't use CRP. There are units that use units in the UK, although I've not practiced there, in conferences here and there, that CRP is used aggressively, especially in colonic anastomosis, to look at leak. They do serial CRPs every day and things like that. We don't have that practice here, at least not in the units I trained and worked. Yes, maybe it can be used.
Because where I work, they used to do CRP along with total count and differential count. And they go about little with that in their mind. So that's why I asked whether we should be doing it or not.
Yeah, so I don't do it routinely, but definitely maybe it can give us a direction if we are confused. Yes. Maternal mortality is almost 0% and rises with delay in surgery for more than 24 hours. So appendicitis is one emergency. Generally, surgeons, we take it easy. If there is an appendicitis at 10 p.m., we will operate it the first case in the next morning, because we know that once it's not something that requires urgent intervention. We can still take a few hours to work the patient up and operate. But yes, there is a risk of rupture and things like that. So we don't usually wait more than 24 hours. As the diagnosis of appendicitis, we operate within 24 hours. And this is a common situation, the delay in surgery in the third trimester, where the diagnosis is more difficult. So is there a role of expectant management of appendicitis in pregnancy? So why am I talking about this? So in surgical practice, when I was training, every appendix means surgery. But over the years, we also know those cases of mild appendicitis. There are patients, they do nothing, it goes away in 24 to 48 hours. There are patients whom we give a course of antibiotics, second, third day, they become better, they start eating and the pain disappears. So these days, we only operate on appendicitis where we're 200% sure this is going to progress. There is imaging evidence of appendicolith. There's perforation, there's complications, things like that. So these days, it's not routine for us to operate every appendix that we see. So that's why I'm discussing. And also because there can be a thought that, why can't we manage this without surgery? It's a pregnant lady after all. So there is not much role for conservative management in pregnancy. I would not like to wait. Having said that, with more and more imaging, because now nobody waits to do an MRI. I mean, anybody in clinical practice, any doubt, immediately they do an MRI. And there are times I've seen reports of subacute appendicitis. Again, this is very, very rampant, so we are tired. So when I clinically know it's appendicitis, I operate. When I radiologically know absolutely for sure it's appendicitis, I operate. So I don't believe in this diagnosis of subacute mild appendicitis radiologically. So in those cases, I don't operate. Yeah. So I'm discussing this here because when you know it's appendicitis in pregnancy, we operate full stop. There's no consideration for conservative management. Coming to gallstone disease. This is my favorite disease because laparoscopic cholecystectomy is my baby. I worked a lot. I've assisted a lot. I started assisting lap when I was in training, my first year of training. And then I've seen only, simple gallbladders being operated, then moved on to acute and chronic cholecystitis, gallbladder perforations, gangrene. So the entire spectrum over the years. And I was lucky to train when the laparoscopy was a boom, when more and more people started doing. And there is also a stage when we saw several complications after laparoscopic, starting with access, port entry, bleeding during pregnancy. And that was also a time when we used to open at the drop of a hat because of bleeding or something that we can't control during surgery. So gallstone disease, it's a clinically significant thing impacting maternal and neonatal outcomes. One of the most common non-obstetric causes requiring surgical interventions during pregnancy, with prevalence affecting up to 12% of pregnant women globally. Pregnancy predisposes women to gallstone formation due to hormonal changes. Progesterone reduces gallbladder contractions, causing bile stasis, while estrogen increases cholesterol concentration in the bile, both promoting stone formation. Gallstone disease in pregnancies are associated with increased risk, including preterm birth, maternal morbidity, maternal readmissions, and neonatal morbidity.
Actually, I find this is more common than appendicitis.
True, ma'am.
In
True.
all these years, even though you're saying appendicitis is the commonest, I've had more cases of gallstone disease. And most of the time, what the obstetricians mistake is, this is mistaken for a gastritis, and they keep on treating for gastritis. If the gastritis doesn't subside within 2 or 3 doses of our pantoprazole and antacid liquids, I think we should have an ultrasound to look for gallstone disease. That's the lesson I have learned. Like whenever there is an epigastric pain, severe, disturbing the food intake, and not subsiding with our routine pantoprazole and other things, look for gallstone disease.
True, ma'am. See, the reported cases of abdominal emergencies which get operated are appendicitis. That is my understanding. So that's why it's reported more and prevalence the most common. But if you see gallstone prevalence, if I when at the slide we showed initially where it is more common, but what percentage undergo surgery? How many of them get picked up early? So we really don't know the numbers. It's true. In my short clinical experience, I see more gallbladder stones. I've operated more pregnant women with stones than appendicitis. So yes, it affects a big percentage of pregnant women because of the hormonal changes in pregnancy. And most cases are managed conservatively, like a case of biliary colic or a case of just belching, burping, abdominal discomfort. Usually we don't tend to operate. But once they develop severe pain, they develop acute cholecystitis, there's no hesitation. It requires an antepartum cholecystectomy. Surgery during pregnancy, including laparoscopy, is feasible in any trimester when medically indicated and is linked to reduced maternal readmission rates because of symptoms. However, conservative management is preferred unless complications arise. So somebody with one episode of biliary colic, I'm willing to wait. Somebody with biliary colic in first trimester, I'll push it to the second trimester to operate. Somebody who's willing to get operated second trimester, I'm willing to operate. Someone who's wary of surgery, they wish to push the third trimester with all due informed consent, I let them be. And once in the third trimester and there is no choice but to operate, I would discuss with the obstetrician and see if we can combine, we do a, early delivery of the baby and then operate. So yes, and complications of gallstone disease, that requires a separate talk. But in short, gallstones can cause problems within the gallbladder, such as a simple colicky pain that comes and goes after a fatty meal. Biliary colic typically comes after dinner. The people eat at 8-9 p.m., go to bed. They wake up after an hour or two with severe pain. It's usually in the epigastrium. Sometimes, they think it's a chest pain. Many patients, they think it's some kind of cardiac emergency. They get ECG done. They're seen by a cardiologist. And much later, when an ultrasound is done, a gallstone is found. So it can present with epigastric pain, chest pain, right upper quadrant pain, radiating to the back, in the right upper part of the back. So that is a classical biliary colic. Usually it lasts for a few hours, 1 to 3 hours. Then the stone that was stuck at the neck of the gallbladder falls back. The pain becomes all right. Many times it's a rush to the emergency. Some IV pan emesit is given. Pain subsides. Patient comes back home. unless an ultrasound is done proactively, it is missed. So this is a standard biliary colic. There are times the stone that is stuck at the neck doesn't fall back into the gallbladder. So that is when the gallbladder swells up. We develop a condition called mucocele. It gets infected, it becomes a pyocele of the gallbladder. And then the gallbladder is palpable. It is tender, globular, palpable mass. And this is for a big stone. There are smaller stones, the complication rates are more. Quite often, patients ask me, even other clinicians ask me that it's only a small stone. Okay, and the more smaller, they are so relaxed. Actually, we are more worried when the stones are smaller, because a small stone can escape the gallbladder and go and cause havoc outside. So it can get stuck in the bile duct. I think I should share a picture. It's being monotonous. Give me a moment, please. Is that visible? It's too small, isn't it? Is this visible? So I'm assuming it's visible.
Yeah, it is.
Yeah, so these stones, so they go and get stuck in the neck, can cause swelling and acute cholecystitis. If they're small, they're tiny, they slip down and block the bile duct, the common bile duct here. And this causes obstructive jaundice. So patient has, so the colicky pain that came and went now is a constant dull ache. And once it is in the bile duct, the pain is severe. And they develop over a period of time, maybe a day or two, they'll yellow eyes, yellow urine. Although yellow urine is the commonest thing, that immediately yellow eyes takes a while. So there's yellowish discoloration of urine, and the stone tends to slip down. And there we can see the pancreatic duct joint. If it blocks the ampulla here, there can be an episode of pancreatitis. The pancreatic enzymes go back and there's pancreatitis. Tiny stones manage to their way out. And that is when the patients have severe pain, very severe pain that goes to the upper back on the right side. They're rolling in pain. And there are times they manage to escape and we are happy. There are times they're stuck and we are terribly unhappy. So these are all the problems these gallstones can cause. So these complicated gallstone disease, such as acute cholecystitis, can increase the risk of preterm delivery, low birth weight, and rarely maternal death. The moment I was going through this, I remember a patient that we had, a mother in the final, I think it must be just preterm. She had gallstone, developed severe pancreatitis. They had to emergently deliver the baby. And she was in the ICU. She never held her baby. She developed necrotizing pancreatitis, led to maternal death. So when somebody says you to a surgeon that you just remove all gallbladders, that's what they say, prophylactic cholecystectomy, I say, no, not true. Gallstones can cause death. It's severe. It is unforgiving, and gallstone can cripple somebody's life. So this particular mother, I still remember, there's a baby outside the ICU. They're expressing her milk. She has developed edema all over the body, severe pancreatitis, necrosis on multiple inotropes. Just can't forget, and after a lot of struggle, gave up her life. So yes, gallstones can cause death. So it is very important to recognize it, refer for surgery. In the era of laparoscopy and safe surgery anesthesia, if we allow a patient to die because of gallstone complication, it is negligence. Biliary sludge. Sludge and sometimes stones can often resolve postpartum. Although about half of symptomatic women during pregnancy, when they had gallstones, may develop symptom recurrence. So in summary, gallstone disease requires careful management, balancing maternal and fetal risks with a preference for conservative therapy unless acute complications necessitate surgical intervention. So coming to the sludge, the moment I thought sludge, see, there is this one recent patient that had sludge. This lady had it during the first trimester when she was evaluated for vomiting, recurrent vomiting, upper abdominal discomfort. She didn't even have a colicky pain or anything. And then she had sludge, the entire gallbladder filled with sludge. And the hyperemesis continued into the second trimester. She was 24 weeks. She couldn't eat anything. She was losing weight. And the gallbladder is filled with sludge. So I've operated on gallbladder sludge during pregnancy as well. We did a lab fully. Immediately symptoms resolved. She was able to eat. So yes, sludge can also cause severe symptoms. It should be kept in mind, although not all sludges require surgery because sludge can disappear in the postpartum period. So what do the guidelines say? So a conservative approach to gallbladder disease in pregnancy is associated with higher maternal morbidity than surgery. Clinicians should be vigilant about complications of gallbladder disease, such as gallstone pancreatitis, since this may be associated with a high risk of fetal mortality as well. In pregnant women with biliary colic, supportive care will lead to resolution of symptoms in most cases. Complicated gallstones require a proactive approach and surgery is required. Should we do lap or open? I mean, I think the argument is over. We know that is lap is superior. The laparoscopic cholecystectomy appears to be associated with better composite maternal and fetal outcomes than open approach, fewer surgical complications, and shorter hospital stay. So is laparoscopy in pregnancy safe for mother and fetus? So in comparison with open surgery, laparoscopy for adnexal and gallbladder disease has no increased risk for mother and fetus. Where appropriate surgical equipment and expertise is available. And that I want to stress, underscore, bold, because now we are in an era where laparoscopy is done in every small place. You just need one room with air conditioner and a tower and laparoscopy is done. Many times there are people, technicians who carry the lab equipment in their vans, go from hospital to hospital. So it's very, very important to ascertain the quality of the equipment, the sterility of the equipment, how it functions. So it is not just that you have an equipment and you operate. It's very, very important to assess the safety of the equipment. And the second thing is expertise. If someone has at least some decent, they've done 100 lap surgeries, they're senior enough to not be scared. I mean, that can't be described. How senior is senior, it is difficult to say. But, you know, the surgeon should put his hand on his heart and say, okay, am I ready? Because it happens that a lot of us surgeons, we finish MS general surgery. When I was training, there was no structured training program. And every hospital has a laparoscopy weekend course. They finish the weekend course and come and start doing lab. And so that kind of practice is not expertise. So expertise is someone who's had a mentor, who's assisted somebody at least in a few hundred cases, who's seen some complications, who's seen difficult lab surgery, who's willing to sweat it and develop the expertise, and then starts doing under the mentor's guidance and then develops an expertise. So that is so, so important. So if the expertise is not there, if there is no safe equipment, and then it is okay to do a laparotomy. It's perfectly okay. It should be explained to the patient attenders. If I'm practicing in a place that doesn't have a proper equipment, I refer them to a place which may be safer, which has better equipment, which has a better surgeon. It's okay. It's perfectly okay. It's good to be honest with yourself and to the patient, yeah, than to cut a sorry figure. So is there a place for open surgery? Yes, if you didn't have the equipment, if you didn't have the expertise to do lab, and the only option was to open, yes, it is right, very well right to open up a patient.
And also probably 30, 32 weeks plus may not be, like technically laparoscopy may be difficult for that woman. So like she had been suffering from second trimester onwards, we had been pushing, and somewhere around 32 to 34 weeks, she has severe pain. Probably an open laparotomy might be a better option than a laparoscopy. And I'm very happy you insisted on the expertise. Thank you.
Because every time I make an incision, so I told you this all comes with bad experiences, because I was in a high volume center. I have seen the Verus needle go into the IVC. I've seen the trocar go into the aorta. I've myself inserted a Verus needle into the liver once. Okay, and pulmonary embolism, bang pulmonary embolism. Very south pulmonary embolism. So I've seen all the possible complications. Trocar into the bowel, Veris into the bowel. So, and things like that. So there's no taking chance. There's no taking risk. And I've trained with a mentor who has done only open technique. Then I trained with a mentor who does only Veris needle technique. So I've been seeing the complications of both. So and now I'm in a situation that, I take a moment before I put my Veris inside. I take a moment and pray that this should be a safe surgery. It can be nothing else but safe. If it can't be safe, the surgery is not required. So that kind of practice, yes. And yeah. So is laparoscopy in pregnancy safe for mother and fetus? So there is no additional risk of fetal malformation or stillbirth in women who undergo non-obstetric lap surgery. The maternal condition which necessitates surgery may be associated with the risk of miscarriage and preterm labor, not the technique of laparoscopy itself. Only experienced laparoscopists should carry out these procedures, and outcomes should be carefully monitored. Joint surgery between gynecologists and surgeons is encouraged. It's important that the obstetrician and gynecologist is in the operating theater. I remember a case of lap appendix. I was called to operate in A for fertility. Dr. Aruna was around. This was a patient who has had some major surgery as a child. So multiple additions. The obstetrician was right next to me when we, did the adhesive lysis and did the appendix. So it is so important that, a joint decision making and agreement is done. Yeah, the decision between lap and open routes should be based upon the available expertise, infrastructure, background history, gestation, etc. The moment I was reading this infrastructure, what strikes is you need a good anesthesiologist, somebody has been exposed to lab, somebody who's seen the effects of carbon dioxide pneumoperitoneum, somebody who knows how to manage it. And that is very, very, very important when somebody does lab. The anesthesiologist's prime importance is his or her expertise. What are the maternal benefits? Yes, laparoscopy is associated with faster recovery, shorter hospital stay, and a trend to lower rate of wound infection. What are the maternal risks from laparoscopy? So the general laparoscopic surgical risks such as hemorrhage, herniation at the port site also apply to laparoscopy during pregnancy. Due to the enlargement of the uterus and subsequent limitation to the visual field and surgical access, there is an increased risk of vascular and organ trauma, in particular uterine perforation. That's a diagrammatic representation to show both sides for lap chole. See, now so the axis is never the umbilical region for a pregnant lady. It is the left upper quadrant. The traditional Palmer's point that we use, the point where there is minimal additions, we go even higher than the Palmer's point, as close to the costal margin. There's a safest space. There's only space there, and the entry site is that. And we use a small trocar. We don't jump and go a blind entry. We do a very pneumo, and we use a small 5mm port for access, and we use a safe trocar instead of a sharp trocar. Situation demands that the patient is affordable. We use a busy port, a port that is transparent. We go along with the camera. So under vision, we enter the abdomen. What are the maternal risks? Again, uterine perforation sounds gross, but that should be running at the back of your head when somebody is doing lab. So uterine perforation, rupture, infection, preterm delivery, laceration to the fetus. Yeah, nothing should happen, but these are all the possibilities. And this, we should keep that in mind. The clinician should be aware that there's increased risk of bleeding due to increased vascularity of uterus and adnexia. So again, what do the guidelines say? These are the American guidelines. So appendicitis management is operative. Appendicectomy technique. So there's no conservative management in appendicitis. Every appendicitis in pregnancy has to be operated upon. Technique of appendicectomy, lap is preferable over open if the uterus is less than the umbilicus size. Lap or open is equal and the uterus is large, like Madam said that if it's 34 weeks, 36 weeks, open is perfectly fine. Cholecystitis management, operative, that is laparoscopy, is better than medical management. If there is only biliary colic one episode or there's some mild symptoms, yes, we can manage non-operatively. So how do we manage non-operatively? Some tips and tricks. Dietary management. One is usually fat triggers a biliary colic pain. So it's imperative to tell the lady to avoid anything that is rich in fat. So what are the foods rich in fat? All animal foods. So chicken, meat, egg, fish, all have fat in them. So no animal foods. In vegetarian foods, no fried foods. And no dairy, no curd, no butter, no cheese, no paneer. So anything that can trigger. So doesn't the pregnant lady require fat? Isn't that a required nutrient? Yes, it's required. The natural wholesome forms of fat, the sources of the nut and seed oils, such as groundnut instead of groundnut oil, coconut instead of coconut oil, till seeds instead of gingerly oil, etc. Sunflower seeds instead of sunflower oil, etc. can be used. So the source of fat given in the package by God, yeah, the source which has fiber in it, nutrients in, yes, that is allowed. Fish in the form of gravy, not fried fish, which is rich in omega-3 fatty acids, allowed. So when somebody has a biliary colic, doesn't want surgery, I strictly tell them to cut off all the fat in their diet and go on a vegan diet without any processed food such as oil. So just fruits, vegetables, nuts and seeds. Nuts about 10, maximum 10 in a day, ideally 5. Seeds, 3 to 4 teaspoons of seeds in a day, like chia seeds, flax seeds, etc. Pulses and rice is what we allow such patients who want to be managed conservatively without surgery in order to not trigger an attack of biliary colic. Choledocholithiasis, CBD stones. CBD stones require prompt removal. There's no sitting and waiting there. It requires a procedure called ERCP, which is an endoscopic procedure to remove the stones from the bile duct. IBD management requires medical management if it's an emergency, like a bowel perforation or bleed, if it requires surgery. So that's my favorite slide, that the audience is a group of practicing clinicians, obstetricians, and gynecologists. This one thing always bothers me. I get an opportunity to tell you all. I find that obstetricians who do laparoscopy, gynecologists who do laparoscopy, they tend to not close the ports. They let it be. Surgeons meticulously close all our ports. So I wish to enlighten that for those who are not closing the ports. So any port in and around the umbilical region, which is 10 mm or more, has to be closed. Any port away from the umbilical regions, left upper quadrant, right upper quadrant, which is 10 mm, can be left. But if there is specimen extraction through a port, which is 10 mm, the port has to be closed. So why? Because there's a risk of hernia formation. It is 1 to 2% in incisions that are 10 mm or more. Therefore, the fascia has to be closed, not the skin alone. And that is a very important recommendation, and it's a request from me to all the fellow practicing gynecologists that kindly close your 10 mm ports, especially around the supraumbilical, infraumbilical. Yes, if you deliver the specimen from any other port, kindly close the fascia. So coming to the end of my presentations, the presentations may be atypical in pregnancy due to anatomical shifts. Consider pregnancy-related anatomical and physiological changes when considering a patient with abdominal pain. Labs may be misleading. Imaging decision must balance diagnostic benefit versus fatal risk. Early consultation with surgeon if an acute abdomen is suspected. I end my talk here, and I'm open to rapid fire from you all. I'm willing to take it. Thanks so much for the opportunity.
How would you differentiate a colitis sort of symptoms, like when irritable bowel syndrome and all comes during pregnancy? It's quite tough to diagnose. Even otherwise, it is very tough. Some few points to diagnose an irritable bowel syndrome, because that we are not going to operate, and that's going to come again and again. So we'll have to face that. How do we some points to diagnose?
Ma'am, this irritable bowel syndrome thing, even in a non-pregnant patient, is is not an easy thing. So, yeah, in my clinical practice, I actually don't label them. Inflammatory bowel disease, yes, it has a pattern.
Okay.
So inflammatory bowel disease, we do see. So there are two types of inflammatory bowel disease. One is ulcerative colitis. The other is Crohn's disease. The symptoms, colitis are usually, it's classical. They have diarrhea, they have blood in the stools, mucus in the stools, and usually they come to a surgeon to get a PR done, or they may go to a general medicine. So there's change in bowel habit. That is very obvious. It is not some belching burping, because these days we have people eating all kinds of junk come with some semi-solid stools. By the way, I remember one patient yesterday. She says she's an IT, describes the stools. She says irritable bowel syndrome. So she says, all my pain has subsided, mucus has gone, blood has gone. But doctor, the stools are floating, it is not sinking. Okay, so that kind of population we see these days. So I said, it's none of your business whether the stools float or sink. Okay, just let it be. So that kind of, that's what we see. They say it's semi-solid, there's a lot of gas. I had one bowel movement in the morning and one more. So usually irritable bowel syndrome is a lot related to stress and food habits. So usually the pattern is they have a bowel movement in the morning, they feel incomplete, they have breakfast, they have another bowel movement, then mid-morning they have coffee chai, they have another bowel movement, usually subsides after lunchtime. That kind of pattern. But inflammatory bowel disease, yes, we know the symptoms, ulcerative colitis, Crohn's, and I would rather overdiagnose than underdiagnose them, immediately refer them to my medical gastroenterology colleagues. If required, a colonoscopy is required, it is done, biopsy is done. There are some labs that are required to diagnose inflammatory bowel disease, those are done. So, it goes along that way. But irritable bowel syndrome in pregnancy, I don't have, you must have seen more cases, ma'am. I don't have experience. But
No,
many
we
times
don't see very often, but I just thought because when somebody comes with repeated abdominal pain and a bowel disturbance, we do refer to the gastroenterologist. But most of the time, the youngsters tend to take it for amoebiasis, and then they just give metronidazole and then antibiotics. And what I want is the patient has to be referred to a gastroenterologist if she comes with the repeated abdominal pain, altered bowel movements, and vague pains relating to food. That's it. And there is a question in the chat box by Dr. Suganya. Is there a specific drug we need to give for patients who opt for conservative management, like UDCA in cholelithiasis patients? When we say conservative, is it just observing them or giving them something?
You may choose to give. So I don't regularly prescribe UDCA, but there are other colleagues who do. So the individual preference, because there's no study that says UDCA given over a period of these many months or years resolves gallstones. We have no evidence. So there's no, first quality evidence saying that, and that's why we are operating gallstones. So you may wish to give. There's no harm. Yes. So yeah, that's my answer. So routinely,
So when we're not sure about whether to give or not, we can't set a timeline also for that for 1 week, 2 weeks.
So I hope that's not contraindicated in pregnancy.
No, we use it liberally for cholestasis of pregnancy. Whenever they come with the pruritus in the 7th, 8th month, we do use that liberally. And there's another question by same Dr. Suganya. What about bleeding PR not cured with diet? Drug of choice. Would you like to prescribe some medications for hemorrhoids during pregnancy?
So yeah, thanks for that question. See, hemorrhoids is a clinical diagnosis, not all blood. Usually bleeding, the common causes of bleeding PR is a fissure. Day 1, day 2 fissure, there is a few drops, and day 3, 4 subsides. So clinically, it's usually painful. It's usually after a bout of constipation. So the first thing I tell them is stop your iron supplement because iron supplements cause constipation at the rear end and severe gastritis at the upper end. So yes, so that is the first thing I do. So if clinically, if it is indeed a fissure, there's no medication required. It's just a change in the dietary habits, change in the lifestyle, such as avoid prolonged sitting, avoid prolonged travel, and things like that. Of course, we give topical application for fissure and ano. For hemorrhoids, the thing is different. See, hemorrhoids, we need to do a proctoscopy. And if you're 100% convinced hemorrhoids and it is bleeding, I offer Daflon. I give Daflon BD for 5 days. And if it subsides, well and good. If it did not, then we need to manage it. So we need to do some intervention to manage. So if it is a hemorrhoid that is grade 1 and 2, it is above the dentate line, we can put a band over it in the office without any anesthesia. That is what I do. If it is grade 3 and 4, it's come out, and I know the patient will have pain if I put a band, and then we need to operate. So yeah, this. But if you look at fissure and hemorrhoids, these are all lifestyle disorders. I won't even call it as a disease because hemorrhoids will be there today. After 3 months, they disappear. See, just because a patient has altered some lifestyle. So this could be a change in the dietary habits. This could be a change in their lifestyle. So they're up and about, physically active, not sitting. So there are so many factors, but I'm not even sure I can describe it as an allopathy practitioner because I've seen hemorrhoid disappear with traditional Indian treatments such as Ayurveda and Siddha. So, and in my understanding, because I've been exposed to hemorrhoids since my first year PG, primarily because I was a lady in most of the units I worked. And a lot of women with any bleeding PR or anything, it was, they were siphoned to my side because nobody wants to do a PR. Nobody wants to do a pile surgery. So I had the privilege of doing multiple rectal exams, especially in women. And I soon came to know that I have my own understanding of this disease. And now that I've matured and I can call myself a senior consultant now. So now I realize that it is not even a disease. These come and go. So I don't jump into operating on hemorrhoids. I don't jump and put in a laser probe and shrink them. No, hemorrhoids is a lifestyle disorder. And certain times, even the change of weather will shrink the hemorrhoids. It is beyond my control to even say what happens. So I give them adequate time. I give them lifestyle modification. I give them a good high fiber diet. I let them drink a lot of fluid. I don't allow them to sit. If it's piles or I have a fissure, I tell them don't sit. You can stand and work on your computer. And it's very, very common in IT professionals. I tell them have a tall desk, stand and work. Do your work standing, walk about, run, do anything. And don't sit on a hard chair. Don't sit on a chair that is a sofa that has Rexine that goes inside, sinks inside. Use a firm chair with a soft cushion on it. So things like these, and they help. I don't know, suddenly they disappear. I do give some laxatives, yes, they're part of the treatment, but hemorrhoids, I don't jump into surgery. And for bleeding hemorrhoids, again, I prescribe Daflon, 3 to 5 days, and usually subsides. Most of the patients subsides. Only the small subset who are on aspirin, clopidogrel, coronary artery disease, antiplatelets, bleeding keeps coming and going, and there's a drop in hemoglobin. That's a situation when we operate hemorrhoids. At least me, that's how I do it. So yes, hemorrhoids or any other bleeding PR, if you are sure it is only that bleeding, yes, you can give Daflon. If you're not sure, it's a small pile mass and clinically there's no blood, it's wise to do a sigmoidoscopy and look higher up where the blood is coming from.
For an external pile mass, which is thrombosed and very painful, this magnesium sulfate dressing helps. What we do, we take magnesium sulfate crystals. That's actually, Maxself dressing is not available as such. I don't know whether it is available ready-made. What we
Available these
normally
days,
do,
yes.
magnesium sulfate crystals that is some 10 to 15 rupees only one packet, some 50 grams. So we powder it, mix it with Vaseline, put it around the pile mass, and keep a gauze, and then ask them to wear their panties. So that actually reduces external thrombus pile mass pain. The mass as such may shrink but never disappears, but that may give relief. That is one important thing. My suggestion, whenever there is a pain abdomen where you're not able to diagnose what it is, like in the sense there are no associated symptoms, gastrointestinal symptoms or urinary symptoms, and you think it is a like it's not obstetric pain also, like not the round ligament pain or the preterm labor, always ask for any stressful situations at home. Most of the time they find this pain abdomen to be an excuse to come to you. So please ask them whether there was something wrong at home, like whether there was a fight. And in those situations, we should ask them and then refer to a psychologist or a psychiatrist, because non-obstetric causes of pain abdomen definitely will be associated with some symptoms of vomiting, diarrhea, or say if it is some neurological. Without any symptoms attributed to these systems and signs that we can detect, if there is a complaint of repeated abdominal pain, I think a psychiatric consultation should be considered. Or if the patient is not willing, probably we should spend a few more minutes with them to find out if there is anything beyond the pain. Thank you, Dr. Jayapriya. We enjoyed your lecture. There were lots of personal anecdotes, and then we really enjoyed it. Thank you.
Thank you, ma'am.
Any other question?
How often is bowel obstruction seen in pregnancy? Have you ever come across? It's also said as one of the cause of acute pain.
True. I have seen bowel obstruction in pregnancy. I've operated upon. It is seen, especially umbilical hernias are quite common in pregnancy. I had operated on a patient with umbilical hernia with small bowel obstruction. It's true. I don't know how common it is in the population. Hernias are common, bowel obstruction is common. If it is there, there's no second thing about it. It requires surgery. Yes, and this particular patient that I've operated only one patient with bowel obstruction, and it was a second or third pregnancy. She was in the mid-trimester, uterus maybe about 20 week size, and we did an open surgery. She recovered. And yes, that is my limited experience of treating patients with bowel obstruction in
I
pregnancy.
had seen one patient, 24 weeks pregnant. She had been coming intermittently. Some days she'll say constipation, and then some days she says she passed motion freely. And then one day she came with diarrhea. When I examined her, there were masses of feces on the left iliac fossa. I could feel that hard masses. I said, it doesn't look like an ordinary diarrhea. Something is wrong. And then we admitted her, we observed her. The stools were very hard when we did a rectal examination. We did give enema, everything. But finally, within 2 days, she went in for a burst abdomen. Like the feces had blocked the bowel, and it was burst bowel, and then surgeon had to come remove about 1 kilo of feces from the abdomen through that colostomy wound. So such things happen. So I think any pain, an examination, proper history will definitely help us.
If there is umbilical hernia you are seeing in a pregnancy, because many times we see the divarication of recti in pregnancy. So how often, I mean, do you advise them if they are going for cesarean to operate on the same sitting?
I
What
do
do you
advise
suggest?
Sudha, like
Yeah.
if it is a large hernia and she has a big divarication, I advise them what is called as dermolipectomy after the second C-section and sterilization. With the help of a plastic surgeon, I have done a few, and I have done even, but that helps a lot. Even though we don't go up to the upper abdomen, in a dermolipectomy, along with the second cesarean section, the umbilical region and the region below that is repaired. In the sense,
Okay.
the rectus is plicated, the umbilical hernia is repaired. Sometimes neo-umbilicals also we do create, and the excess skin and fat is cut off. But whereas we don't go to the upper abdomen. So the upper abdomen will be there, but it helps a lot even cosmetically. But many of them will not be willing actually. One, the cost factor, and nowadays, whatever extra you suggest, they always think it is because we are after money. So they don't accept. But I have done around 20, 30 cases myself.
Thank you, ma'am. Thank you, ma'am, for that
I have
advice.
a different opinion on this, madam.
Yeah, sure.
We do see a lot of divarication in pregnancy. We do see umbilical hernias in pregnancy. And as long as they are not symptomatic, they are tiny, too little, only omentum is content, no complications, I don't touch. And regarding
We don't touch when it is small. When there is a large divarication, they
yeah,
have
so
an ever pregnant look. No, I always ask them after your first pregnancy, did people keep on asking, "Are you pregnant? Are you pregnant?" And they say yes. And I usually use the pinch test. I pinch the skin and skin below the umbilicus. When I'm able to get a fold of skin for about 5 to 10 centimeters, I'm able to pinch. Then there is a lot of lax abdominal wall, that apron sort of thing, which comes and hides even the mons pubis. That sort of patients we recommend, and definitely when it is an umbilical hernia associated one, I do a repair with the surgeon, plastic surgeon.
I was coming there, ma'am. So the tiny hernia in pregnancy, I don't encourage. During delivery, combining a C-section with an umbilical hernia repair. So again here, if it's a lot of divarication and is a big wide-mouthed hernia, I know it's not going to get obstructed. I let it be, because any kind of surgery in the pregnant woman that is other than cesarean, I would prefer to do it in the postpartum after 6 weeks. There's a lot of change in the skin, fat, and the maternal tissue, even wound healing for that matter. I don't know how cesarean sections heal, but I say that any wound in the first 6 weeks, it's very, very challenging. In the postpartum period, magically, certain magics happen in the lady's body, better. So I prefer to do any elective surgery on a separate occasion, ideally once the postpartum period is over. And of course, the patient will have challenges feeding the baby and things like that. So if it is not symptomatic and if it's cosmetic, it is better to do it electively and not combined with a cesarean. There
You're
are times-
absolutely true. But since many of our patients will not come back for a second surgery for such causes, I have told them the pros and cons, and those who are willing, we have taken up. You're absolutely true that we don't want to combine unnecessary surgeries along with cesarean section. But this dermal lipectomy takes another 45 minutes or so. And the incision, which is 10 centimeter for a C-section, becomes 20 centimeter with a dermal lipectomy. The hospital stay cost, anesthesia cost, everything goes along with that. So that is one of the reasons we used to advise. But
It's
definitely only
some kind of
patient after.
abdominoplasty that you're suggesting, isn't it, ma'am?
Yes, yes.
Some kind of tummy tuck.
Yeah, abdominoplasty, tummy tucking. Thank you. Any other question from anyone else?
Thank you so much.
Thank you all of you for attending this meeting. Thank you, Dr. Jayapriya.
Ma'am, hello.
Yeah.
Yeah, ma'am. On last question, ma'am. Actually, I do have a patient with divarication of recti, ma'am.
Yeah.
I'm going to operate her in another 2 weeks, ma'am. Actually, I
Okay.
discussed with my surgeon. He told like I have to finish off my surgery and then come back for a divarication repair, ma'am.
Yeah.
Actually, patient was asking like, can we do a combined surgery of like C-section because she's a like previous LSCS, ma'am. So like she asked me, can we do the procedure combinedly?
Yeah,
But
we can do. See, but thing is, it is not, the results are not as good as it is if you operate on a non-pregnant postnatal woman who has recovered. But
Okay.
the reason why I was suggesting and then doing was many of these patients will not come back for a, and their fat, like the extra
Okay.
amount of
Thanks.
fat and divarication will be so much that you feel bad for them. So
Okay, ma'am. Okay. So
definitely
how
it can
many
be
months
combined.
I need to postpone, ma'am? Like it is like 6 weeks, or I can advise.
No. If you are going to do after delivery, why you want to do in 6 weeks? It's not an emergency. So probably after a year or so, when they are willing for an interval sterilization, we can combine. But if they are willing to have it along with the C-section, we can go ahead and do it. But please explain to them that it's not going to produce a perfect scaphoid abdomen. Okay. So it will be the lower abdomen, extra fat and skin, lax skin will go. Some plication of the rectus can be done. It can be done, but not an ideal situation.
Can I ask this forum, because all of you are practicing obstetricians and gynecologists. So how long does it take for the tummy to go back to the pre-pregnant state? Because there is a small group of patients that come to me after delivery and says, "Vair ulla pogala." The tummy has not gone back to its original state. And no amount of abdominal crunches or nothing helps.
Yes, only 5 to 10% of the Indian women get back their old tummies. Most of them put
That
on
is a
so
very
much
small
weight.
number, ma'am. That is a very small number. I mean, it's not that bad.
Yes, most of them have. That is the reason. You should ask the patient who had undergone this sort of tummy reduction how happy they were. There was one patient who came for an interval sterilization with a large divarication. With like, she looked pregnant, 34 weeks pregnancy, like so a tummy. Then we suggested you have the sterilization and the tummy reduction. And when she went back, her tummy was so flat, she was so happy. So that sort of
I generally tend to avoid, because they'll say you just delivered and it's a small baby, you're feeding. So I postpone it to 1.5 years. I said, you come back,
Yes.
the child is 1.5.
will the patient come back? That's a question.
I don't know if they require, they do.
No, it is a cosmetic surgery mostly, and especially those women who have diabetes, especially gestational diabetes, where the lower abdomen fat is high. You remove the fat and they are able to exercise better, because one fat abdomen hanging down, they won't even be able to squat on the floor and then eat. This tummy will be obstructing sort of. So these patients find a flat tummy is so helpful for walking and running. So you should get the experience of the people who underwent that surgery. I've done quite a few, as I said, and it is good. And I've not regretted at any point of time why I did that at this time. Thank you. Thank you, Jayapriya. Thank you, all of you.
Thanks, ma'am. Thanks for
Thank
the
you.
opportunity. Thanks for
Okay, Sahiti will end up